Hi, and thank you for joining us right here at Prostate Cancer Live. My name's Todd Hartley, and I'm joined by our medical director, Rich Bevan-Thomas, out of Arlington, Texas. Doc RBT, thanks for joining us.
Hey, I'm good, Todd. It's good to see you again tonight.
Good to see you too. Now, listen, before we get started, and tonight we're going to talk about active surveillance and really some interesting nuances of active surveillance for prostate cancer. But for anybody who's out there in our audience that wants to submit in a question, by all means, you know the drill. You can go to the event page on Google+, post your question. If it fits within the context of the topic, then I'm going to ask RBT. But remember, no case-specific questions. We're just not allowed to answer them. They're best answered by your physician. Instead, if you've got a general question, feel free to post it, and we'll bring it up here in the conversation. So, Doc RBT, active surveillance. For those who are just tuning in, there's a lot of information on Prostate Cancer Live about it, but give us a quick overview.
So, Todd, again, we've talked about this multiple times before. I think active surveillance, it's really taken a huge role over the last 5 years in prostate cancer. And again, just to kind of go down a little bit on memory lane, what is active surveillance? Active surveillance is actually where we actively follow patients with low-grade and low-risk prostate cancer. Again, so we're looking at patients, we're not forgetting about them, and we're following them to make sure that they actually are not at increased risk of having that cancer, get outside that prostate, get into the lymph nodes, and potentially cause problems. And in active surveillance, what we're doing, again, is following those patients very, very closely. Now, again, there's different protocols on that. Most people are actually using this protocol where we are following the PSAs. We try to make sure that they actually fit into one of those categories. From an NCCN guideline-wise, the most ideal candidates are very low risk and low risk, right? You can potentially do some intermediate risk. We'll talk about that here in just a second. But we're following those patients. So if you fit into one of those categories, you could be a patient that we follow. And how do we follow them? We do PSA readings, and we do those routinely every 3 to 6 months, and we repeat biopsies at sequential intervals. If any of those things change, or maybe the patient gets nervous, we say, you know what, it's time to do something about this cancer. So we're actively following it. That's why it's called active surveillance.
Okay, now for anybody who's scoring and playing along at home, Doc RBT just said the word again 7 times in his introduction. So for anybody who's listening, there's information about this on our website. That point is clear. Is active surveillance the same for all men?
No, it's not. Wait, let me say that one more time, right?
Again.
No, it's not, right? So anyway, just in case anybody wants to get the inside scoop on this, and the inside joke is that Todd and I have this sort of little thing where I like to refer to some of our old video casts, because I like to have people, kind of look at some of those things. I think you got a fair amount of information on that. And Todd likes to just live in the moment. He's sort of like a mindful kind of person. Me, I like to stroll down memory lane every now and then, right? Because that's how we roll, right? So,
right.
Okay. So let's go down and try to figure out active surveillance. Is it the same for all men? And the answer is it's really not. And this is what we're finding now. So again, let's stroll down memory lane. Let's look at all those guys. So over the last 10 years, 15 years, give or take, we've now found that there are a subset of men who actually, again, have these low risk and very low risk, cancers that we can follow. And again, we can potentially put them on following them. And again, active surveillance, right? So for those men, is it the same guy? So if I'm African American, or if I'm Asian, or maybe I'm from Fiji, or maybe I'm Caucasian, is it the same for all of these men? And the answer is we're actually finding out data now that it potentially is not. And here's what we're finding is that, and in particular, we're going to be isolating, we're going to be looking at African Americans, and the reason why is because, from a genetic pattern, there is a concern that African Americans with that type of prostate cancer, they may have a specific genetic variant, at least potentially, that may cause a further increased growth in some of those cancers. And unfortunately, we just don't have as many African American men on active surveillance as we do, Caucasian and sometimes Asian and some of the other population. But what we're finding is of the men who are African American on active surveillance, we're seeing a change in those cancers actually at an increased rate than men that are Caucasian. And that's actually a very important point. So like many times as I've said here before is that approach active surveillance with caution. We do it all the time. We follow these patients. But again, we always want to make sure that, we're finding that sweet spot for those patients.
All right, so how do you determine who's a candidate for it or not?
Right. So why don't we go back to our NCCN guidelines on video,
and just so you know, there's a whole video where Doc RBT and I go over that NCCN guidelines, but and just a quick on what the NCCN guideline is, and then kind of tell us how it's figured out.
Yeah, so again, what do? So we actually, when man gets diagnosed with prostate cancer, we'll look at their Gleason grade, we'll look at their PSA, and again, their stage that's involved in that as well. And we'll put all those into this formula, and it lets us know what risk category they're in. Very low, intermediate, or high risk. And you can imagine the higher the risk you are, the higher risk of progression that you have of this cancer. Okay, so ideally, the men, as you would imagine, very low and low risk of progression, those are the patients that you can potentially follow pretty closely, right? Okay, but the problem is that the patients in the low risk category, so we've got the very, very low risk, or it's not very, very low, it's very low, right? I said too many varies, right? So strike that, let's take just one vary, you only got one. Very low risk category, those men have what's called a PSA density, PSA divided by the volume of the prostate, which is actually below 0.15. Right? So that's the magic number that we're looking here is 0.15. Now, why is that? So I think this is an important point because this is what we're looking at for all men right now, is that with that PSA, if you have a small prostate, so let's say for argument's sake, I've got a tiny little prostate at 20 grams, and I've got a PSA that's give or take about 9 or 10, right? Or 9, let's say 9, right? So if I've got a PSA of 9 and my volume is 20, so if I have or PSA of a 9, okay, divided by a 20-gram prostate. So you do the math on that one. But at the end of the day, it's actually going to be more than 0.15, right? And the bottom line is that if that PSA is more than 0.15, that's a problem, because that's a problem for a guy that we're saying, does it make sense? Is this tiny little cancer that's in there, is that the only thing that could be causing that elevated PSA? And the answer is, we don't think so, right? So if we're seeing a high PSA, small prostate, and we've only found one focus of cancer, there is a higher risk that that guy has either a higher volume of cancer or a higher grade of cancer that's causing that PSA to go up. So we got to say, wait a minute, let's put the brakes on this thing, right? Should we follow this guy on active surveillance, okay? Because that may be to increase risk. Now in the low risk category, we don't care about the density, right? We care about it in the very low risk, but it's not a factor in the low risk. But let's think about this. It's going to make a difference. So if we're looking at those patients who actually are African Americans, that PSA density actually can play a much more important role.
Okay, super interesting. So, one of the things that we're talking about tonight is about how active surveillance is different from between different ethnicities, and Doc RBT is doing a good job setting up the guidelines and where you fit in. Is active surveillance something that's for the right patients readily accepted across your industry? I mean, you go to these conferences all the time, and you're reporting live and bringing us back the latest news. Is it a controversial subject?
So, it really isn't. The problem is that it's very underutilized. And, we pretty much know this for a while, is the fact that we know that there's numerous men that are good candidates to be on active surveillance, but for one reason or another, maybe their doctor didn't tell them about it, maybe they, maybe they just, sort of phrased it in such a way that, you can follow the cancer, but I don't know about that, so I think it's really educating those patients and making sure that they understand that it's at least a potential option. So again, there's a lot of different factors into that. We know that it's underutilized as an option for specific patients, no doubt about it. But I think, as one of my medical oncologists described it, it's very en vogue right now, or what's he calls it's quite fashionable to be, in active surveillance. And you can call it fashionable, you can call it what you like. But the bottom line is that that for the right men, it can be very helpful. And we've talked about, there's other things that we can use to delineate those patients and try to figure out, in detail, again, using the Oncotype DX test to get a better genetic evaluation of those cancer cells, to put them in that risk. Are they very low? Are they low? Or are they intermediate risk? But again, what we're talking about here is one step above that, which is the fact of, do we need to start looking at, men in different races, and in particular African Americans, are they going to be at increased risk for progression? We may be able to take a Caucasian male who's 58 years old with a PSA density of 0.19 with 2 or 3 areas of Gleason 6 prostate cancer, but he may not be the same guy as an African American. And so, for those guys, I think, consider using the Oncotype DX and really chat with them about the potential that, we may or may not be the right guys for active surveillance. One of the problems is, yes, we are underutilizing that. I will admit that all day long. I think we, at USMD, we really try to do our best to make sure that patients understand which risk category that they go in. But I think the flip side of this is that we don't want to overutilize it. And then we've seen that on specific cases as well. If you overutilize it, you can't really go back in time. So however much I like to tell you, let's go back in time and look at our own videos, right? We can't really do that with prostate cancer. So we want to make sure, again, that we're not exposing these patients to risk, albeit very low. But again, our best chance of treating those guys, all these men, is actually when we get that cancer early, and again, before it actually gets outside of the prostate and continues to progress.
So you really have to take all the available information that you have on a patient and then put together a recommendation on treatment options. Is that part of your job that you do on a daily basis?
Every day, a patient walks in, and the first thing we do, and I think this, and again, this happens with almost all cancers. When somebody comes over to, USMD in the cancer center, the first thing we do is we sit down with them, we'll go over all of their information, and then again, we classify them. And then for us, we use the NCCN, that stands for National Comprehensive Cancer Network Guidelines. It's universal, it's very well designed, and it actually lets us at least stratify those patients. And again, from there, then it starts the dialogue forward of, okay, well, what do we do with this guy? What are our options for these patients? That's not something. The guy walks in with a Gleason 9 prostate cancer. The first thing I say to him is, okay, normally we have these pathways. One pathway is potentially following the cancer. The other pathway is treating it. Well, I got news for you. We can't follow this cancer. Way too risky. So we're going to throw that in the trash. Now we get down to the nuts and bolts of this thing and try to figure out how we're actually going to treat this cancer.
But traditionally, it's been or historically maybe I should say, that somebody that has a Gleason 9 would get a similar treatment than somebody who has a less aggressive, and now you're kind of being able to stratify their risk?
Right. So, and that's it. So, again, I think that, again, to quote my medical oncology friend, that it's become more fashionable for active surveillance, is that, yeah, we're actually finding those men with these lower risks. 10 years ago, a guy with Gleason 6 prostate cancer would be given very similar options. We're looking at radiation versus surgery. We very likely would be doing more aggressive therapy on that Gleason 9 versus the Gleason 6. But nonetheless, we wouldn't really be talking about that. And now it's definitely an option for patients. They just need to know that it's out there.
One of the big topics that comes up at Prostate Cancer Live often is about the the individual treatment decisions that each patient's making and what those long-term impacts are. So if when you give somebody their results, like let's say on an Oncotype DX test, and they have and it's recommended that they follow the path of active surveillance, is it common for them to push back and want to take a more aggressive approach?
So, it's interesting. I think that the more educated patients are, you would expect that, and this is what, when we first started offering active surveillance, again, 4 or 5 years ago, that was the first thing we expected, was patients would say, well, look, doc, I got cancer, I got to get this thing out, I got to do something about this. And what happens now is that more and more and again, I think this is really just from an education perspective, and people understand that, once they know I've got a lower grade, a slower growing, cancer, is that they actually feel pretty comfortable as a whole, following this as active surveillance. Now, I can't tell you every man does that, but I think that, certainly I would tell you that at least, and this is a ballpark figure, probably about 70% of our men who are good candidates for active surveillance end up going and staying on active surveillance. And there's roughly somewhere in the ballpark around 20 or 30% say, you know what, it's just something I want to be more aggressive with. And they tend to be either younger men or men that have, either seen prostate cancer, had affected either their lives or a friend's life, and they say, look, I know that there are some risks, whether it's radiation or surgery or cryo, and they just say, look, I would feel happier treating this cancer. I get what you're telling me, but I just want to treat this. But it's not as high as you think. And that's the issue, is that people say this all the time, that, geez, we're diagnosing all these low-grade prostate cancer, and every guy's going off to surgery. And, interestingly enough, is that if you present it and you get these patients educated, that's actually not the case.
Well, he's Doc RBT. He's the medical director here at Prostate Cancer Live. And, we routinely connect up like this. He's in Texas. I'm in Arizona, where Prostate Cancer Live is based out of. Yeah, exactly. And it's part of our mission to make sure that we can address the hot topics that are happening inside of prostate cancer and bring that discussion right back to you. And in the coming weeks, we're going to be talking about not only more about active surveillance, because Doc Bevan-Thomas had mentioned to me before we went on that we're going to dig a little deeper once we start to understand more about how active surveillance affects different types of ethnicities. But we're also going to bring you the latest news and information as it becomes available. And then part of our goal, and Doc, if I'm wrong here, you correct me, but part of our goal is to make sure that we can explain these issues in simple to understand terms, like we hope that we did tonight. So on behalf of Doc Rich Bevan-Thomas at USMD in Arlington, Texas, and the team at Prostate Cancer Live, we want to wish all of you a very healthy and happy evening. And by all means, if you have a question that you want to submit in that you think would be a great conversation, we're always open to that. We'll look forward
or
to
even a
getting
topic, Todd. Even to interrupt you, but even a topic. Some people want to talk about, maybe the effect of MRIs and how we're using those, with biopsies. That's something we're gonna pursue, and we're gonna chat, about it over the coming months. But if somebody has a topic that they want us to discuss, we'll talk about the latest news around that. And again, we can kind of cut and splice some of these things so that people can clip on those. So
that's really what our purpose here is here. And now there's 107,000 followers socially. So we look forward to your feedback and your guidance as we continue to provide a really powerful resource to patients and their loved ones. So everyone, happy and healthy evening. We'll look forward to chatting with you all very soon. Thank you very much, RBT, for joining us.
All right, thanks, Todd. We'll see you guys.